So welcome everybody to this roundtable discussion on the topic of disrespectful maternity care. And this is part of our course on global maternal health, cultural perceptions and policy approaches. So just to give a bit of background, as we've been learning in this course, there have been decades of efforts, especially in low and middle income countries, to address the very high rates of maternal and infant mortality and morbidity. But these rates remain stubbornly high in some parts of the world, and especially in some parts of sub-Saharan Africa. So one of the pillars of global health policy that we've been looking at to address this problem has been the deployment of skilled birthing attendants or skilled birthing care in a clinical setting, a clinic or a hospital. But what we're finding is that uptake of this care has actually been lower than anticipated for many different reasons. One of the reasons that has been documented is that mothers feel that they are getting disrespectful care at the clinic, and so they are reluctant to go to the clinic. So that's what we're going to focus on today. And we are very fortunate to have with us Professor Adrienne Strong, who is Assistant Professor of Anthropology at the University of Florida. And she is also the lead author of the article, Re-examining Norms of Disrespect and Abuse in the Second Stage of Labor in a Tanzanian Maternity Care. So that's what we're going to be discussing. But I wanted to add that Adrienne has also written a book looking more broadly at these issues called Documenting Death. And very happy to say this is open access. So will also be accessible as part of this course. So here to discuss this issue with us, we also have Dr. Babasola Okusanya, who is Associate Professor of Obstetrics and Gynecology at Lagos University Teaching Hospital. And he's also a practicing obstetric gynecologist at Lagos Hospital. And we are very proud to say he's also a graduate from our doctoral program here at University of Arizona College of Public Health. So thank you so much for joining us, Dr. Okusanya and Dr. Strong. And we also have with us here Dr. Abidemi Okechukwu, who is a public health physician, also from Nigeria, and she is in our DRPH program here at the College of Public Health. And then we have Erika Barton, who is senior undergraduate student in the BS in public health. I don't know if you want to add anything?
Yeah, I'm very happy to be here. I have an emphasis in global health and a minor in emergency and medical services. I'm very fortunate to be here with you all.
Okay, great. So let's start the discussion. And I wanted to start, you were going to ask the first question, Erika. Sorry. Go ahead.
Dr. Strong, in your article, you present a perspective of nurses in a Tanzanian hospital who sometimes hit or yell at a mother during the second stages of labor. What is the nurse's explanation for why they do this?
Yeah, so this is a great starting point, and different nurses, of course, have different responses based on kind of the time that they've been practicing and their experiences, and of course, everybody's own individual personality affects how they practice, right? But I was really interested in trying to understand in this article, in a very specific part of the labor and delivery process, what nurses felt like they were doing and what was motivating what was happening. So often I would see disrespectful behaviors kind of throughout the nurses' interactions with women. And there were a lot of times where it really seemed like there was no purpose at all other than kind of what we see in other literature in terms of shaming women or reprimanding them for not following instructions or viewing them as being non-compliant and yelling at them for not following directions or whatever. But I was really fascinated by this time when women are pushing the baby out. And sometimes this can take, I mean, it can take a very short period of time. Sometimes it can take a couple of hours. So this is where I saw a lot of interactions that really distressed me from the nurses. They would yell, they would slap women's legs, they would hit them, they would forcibly pull people's legs apart. And I really wanted to go beyond my own interpretations of what was happening to try to understand what the nurses thought they were accomplishing when they were doing this. So they told me that sometimes it could depend, but sometimes women needed to be hit in order for them to focus on pushing and be able to push out the baby successfully. So sometimes they would say, especially in the case of first-time mothers, they might say that the woman was scared, or she was afraid of the pain, or she was too tired and was relaxing when she really needed to be concentrating and pushing. And so they would slap her or yell at her to try to bring her focus back to the task at hand. And this was really motivated by a concern that if the pushing stage lasted too long, then the baby would maybe lack oxygen supply, or start to get the meconium in their mouths, or a variety of other dangerous problems that the nurses felt would result from a prolonged second stage of pushing. And so this was a way they felt they could motivate women to push in a purposeful manner so that the baby could come out and be healthy and everybody would have reduced risks. If you dig a little bit deeper, there were also nurses who would tell me that a stillbirth that might result from prolonged pushing or other complications could look bad for them as the provider. And so they were also trying to manage their own reputations and their own outcomes and the statistics for the hospital and things like that by trying to reduce those intrapartum stillbirths by ensuring that the baby was born quickly. And so that was another factor that some of them talked to me about.
Thank you. That really sort of brings your article to life, I think. And so, Dr. Okusanya, in your experience, have you seen any similar practices in settings where you're working in Nigeria?
Yeah, thank you, Dr. Magrath. And yes, I've seen quite similar experiences. I've been lucky to work at these different levels of healthcare delivery system in Nigeria. I've had to do supervisory roles at the primary healthcare center when I worked in the northern parts of Nigeria. Northern parts of Nigeria is a place where we have the least number of health workers in Nigeria compared to the south, where I currently work. And while I was in the northern parts of Nigeria, the most you have in many government hospitals were midwives, and then supported by community health extension workers. So what Adrienne actually reported in her publication, I could easily come to terms with them. There are things I've observed. There are things that occur quite commonly, particularly as you go from the primary to the secondary, but less often at the tertiary level of care where I currently work. So they're actually real, and they are everywhere in low and middle income countries like Tanzania, Nigeria inclusive. Having said that, the occurrence also depends on the caliber of staff, the knowledge of the staff. And I can also say that between, say, a decade ago and now, things have actually improved. The improvements partly because there is more dissemination on evidence-based practices in the second stage of labor. Improvements also because in many settings, there are better staffing, including people of higher cadre with more nurses and midwives, gradually replacing the community health extension workers, and where possible with physicians, obstetricians inclusive, replacing and supervising the nurses and midwives. So things could be as bad as she has described, but in some settings, things could also be much better than described in that article.
Well, that's great to have an encouraging idea of where things are moving in the right direction anyway. So that's great. So Dr. Okechukwu, would you like to add anything from the public health perspective, from your experience?
Yeah, so thank you, Dr. Magrath. I think I agree with what Adrienne and Babs talked about in terms of the occurrences, but also I bring the public health perspective just to remind students and our listeners that these events do not only occur in lower or middle income countries. They're widespread, they occur, and just to see disrespectful maternity care as a spectrum. So a lot of the hitting, the physical abuse or the verbal abuse, those are very common, but there are also passive, disrespectful behaviors that women or birthing people encounter across the world. So I bring the perspective that yes, there is the physical aspect, there's the verbal aspect, but also we must think of obstetric violence in terms of a spectrum, going from where women's complaints are sort of like ignored, or their past medical histories are sort of like not considered, or everything is medicalized, or women are not considered to be able to make decisions or choices that influence themselves or their babies. And so we must consider that in the light of all that has been said.
And Abby and I are actually working on Title V Arizona State Maternal and Child Needs Assessment. And so this perspective, we're actually seeing that in the interviews that we're conducting in Arizona as well. So thank you very much for that. So yeah, Erika, did you want to?
Yeah, so this is a question for anyone that would like to answer. When nurses say that they slap a mother because it's necessary to prevent a stillbirth or avoid a stillbirth, what is your response to this explanation?
Just briefly, I can hop in and say that I think a lot of that is learned on the job. A lot of nurses will say this is not something that they learn in training. And I think training programs now in school, they are talking a lot more about respectful care and good practices in respectful maternity care. But when then these new school graduates go and join a setting where there are much more senior nurses who have been practicing for many years, they don't really have the power to maybe say, oh, this isn't the best practice, because in this kind of hierarchy of age and authority, they're at the bottom. And so I think it becomes something that they see, and then they start patterning themselves off of some of these more senior people who, in my article, I suggest these are people who we should target for greater training and for any interventions, because they are the examples for the younger generations of nurses as well. So there are even some of the experienced ones will say this is not something we learned in our textbooks or in our classes, and it is against nursing ethics to be hitting our patients. But I think ultimately they lack an understanding of other alternatives that might be effective, or they become used to the constraints of their setting and then feel like they can't try anything else. There were times where I suggested, well, why don't we see if she can try pushing in a squatting position where she's more upright, and maybe that provides some extra room in the pelvic opening. And the nurses would go, no, we have too many people, we don't have enough staff, we can't do that, the beds are unsafe, this and that. And they would come up with a lot of reasons for why some of these alternatives were not possible in their setting.
Very interesting. Dr. Okusanya, can you add anything in terms of the actual, how would you avoid the risk of stillbirth? And is there any validity to the idea that, you know, the mother has to concentrate and the mother has to push? And is there any, from the medical perspective, would you be able to comment on how the nurses explain how it would reduce a stillbirth risk?
Yeah. Regarding stillbirth in the second stage of labor, one of the challenges we've had until recently has to do with the information on what's the actual duration of second stage of labor is. As a trainee many years ago, we were taught, oh, if a woman has delivered before, it should be within 30 minutes to 1 hour maximum. And for those who are delivering for the first time, it should be 1 hour to 2 hours. Recent evidence has shown that these were just expert opinions with no proven evidence to actually support what the actual duration of labor is. While there is no clear-cut duration of second stage of labor, we now know that evidence in the last 2-3 years has shown that regarding the first stage of labor, every woman should have his own pathway, unlike the 12 hours we always knew was the norm for first stage of labor. And extrapolating from that, most likely every woman also should also have her own pathway in the second stage of labor, as long as we can do the fetal monitoring and the fetal oxygenation is fine, there's no fetal desaturation. One should be able to let the woman be in second stage of labor for as long as that permits. Having said that, I also want to believe that one of the challenges with slapping or yelling in the second stage of labor has to do with what the curriculum in the medical school or the school of midwifery had. Most of the research on respectful birth started barely 5 years ago, 2016 or thereabouts. And this was when they saw how much the burden of disrespectful and abusive care to women are. And that's also led to the introduction of a theme or content into the curriculum of the School of Midwifery and even regarding medical students' curriculum. So just like Adrienne had said, I'm hoping that in the next couple of years, we'll have new crop of midwives, new crop of medical doctors who will deal with every woman, be it in first or second stage of labor, more respectfully than what we have now. In the interim, one of the ways to stopping that, or at least ameliorating this challenge, will be to do on-site training for those already employed. So, and that's, I know that's been done, so that they can know that you actually achieve nothing in yelling at a woman or slapping the woman. You achieve nothing, doesn't make her to push, rather it actually weakens her the more and makes the push you want her to do to be less efficient.
Thank you. That's fascinating. Did you want to add anything on that topic?
Yeah, I could just add that, yes, just as I think the central theme here is really training, providing the tools for better care. And also there's been a lot of push in that area in public health, with things like training such as helping babies breathe. So some of the fears around you don't want to lose your baby, all those fears that create this bad behavior, like we say, they can be addressed by just training, good training. How do you help a baby that is born? How do you improve breathing so that the baby has better survival? How do you better manage the mother's bleeding, at this second stage of labor? So there are sort of like public health trainings that are being put in place to really train at different cadres, whether you're practicing in a small village hospital or you are even working in a tertiary clinic in the city. So I think the central thing to this is if we can equip nurses and clinicians, nurses, doctors, with appropriate training, helping them think through what they should do if there are complications and there are issues, we can better manage these behaviors and we can change the behaviors to a more positive one. And supportive one.
I did notice though that Dr. Okusanya mentioned something about measuring the oxygen level. And so that sort of made me think, well, what if you don't have the equipment that you need to measure the oxygen level? Then basically, I think the situation where Dr. Strong is working, they would basically, how would they know? I don't know if you want to respond to that. They would just be guessing, basically.
Yeah, I mean, and there's not even any sort of continuous fetal monitoring available. They're still using the Pinard horn, which is a very, very basic tool. And that's really also predicated on user knowledge and error, right? And you have to actually be able to do it intermittently at the very least. And you can miss a lot of things during some of these critical points. So the technology also, or the lack thereof, can really hamper what some of these nurse midwives are able to do and what they know. And I also want to say that Babs brought up the really important point of staffing levels, because if you're in a very busy hospital setting and you have far too few midwives, then you don't feel that you have the time to spend 3 hours with supporting one woman who is in the second stage of labor. You feel like you have to move on to the next person and the next person and the next person, because you just don't have enough personnel. And so addressing that is something that we can all make recommendations about, but ultimately is often left up to governments and how they decide to allocate their resources when we're talking about public health sectors, where the staffing is determined by the government, as it is in most facilities in Tanzania, for instance. So they have to decide to invest in making this a priority.
Right. Do you see any signs of that happening in Tanzania?
It's sort of 3 steps forward, 2 steps back, I feel. I was just in Tanzania and talking to a lot of my friends and colleagues, people that I've worked with in these health settings. They can, as administrators, they can request, let's say they request 10 new midwives, the government might give them 4. And so you're always functioning at a deficit. And so even if you really needed 10 and you got 4, okay, 4 is better than 0, but it's still not the number that you need to really adequately care for the patients. And so I think this is a chronic problem. And there was a point where they were getting more people hired more quickly, straight out of school, and that was going well. And then there was a certificate verification exercise to make sure everyone had really completed the trainings they said they had and things like that. And then a whole wave of people were fired because they were found to have along the way some kind of fabricated certificate, even though they had been working well in these settings for many years, for instance. So then you were back to a deficit again, and they put a hiring freeze around the same time for a period. So it's always kind of, like I said, a little bit forward, a little bit back, and hopefully one day we'll get to a point where it's not a chronic problem.
Well, you do hear about staff shortages everywhere, I think, all over the world. Did you want to add something about that?
Yeah, it's interesting that, everywhere in the world, some of the initiatives that have been done in the past, I can speak for Nigeria, is really finding a way to deploy trained midwives who would normally live in the urban areas, giving them incentives and motivating them to sort of do part-time work in the rural areas. One of the new initiatives is actually, there was a World Bank initiative in Nigeria that was strengthening each individual facility. So you would provide some funding, some support. It's called performance-based financing. So you provide some support to the facility. You would empower sort of like the facility lead, which is usually a midwife, to buy equipment. They'll run on things like solar equipment to provide power, monitoring equipment that can run on solar, giving them some pot of funds as an investment where they could reinvest back into the facility. So it's very, it's really at the micro level, the very, facility-based level, but imagine if that happens across multiple facilities, particularly if you use the hub and spoke methods of maternity facilities, where one facility can feed a large area and provide that birth support for women. I think there are opportunities to really improve care in the sort of the hub facilities, and that can provide even emergency obstetric care and basic obstetric care to women in that area and serve the catchment area. So those are just some of the investments that are ongoing in global health to improve and really address maternal mortality and neonatal mortality. Yeah, and also that's sort of going to improve respectful maternity care.
Great. So we did want to discuss more about possible interventions, but before we go there, I do think there's another very powerful concept in Dr. Strong's article, and that is, in order to understand, what is at stake in the second stage of labor and why they are so desperate to avoid a stillbirth. So, Dr. Strong, you use the term social risk in relation to the stillbirth. Can you elaborate that a little bit? Because I think that could be a useful concept for public health, that maybe public health people are not very aware of that concept.
Yeah, and this really came out of work both with nurses and also with community members, and also builds on a pretty good history of data collection and ethnography in other places in sub-Saharan Africa as well, when it comes to understanding sort of the threats or the stakes involved in reproduction for a lot of people across the continent. And of course, I'm speaking specifically about Africa here because that's what I've written about and that's what I'm an expert in, but I think the same thing applies in many other settings globally as well, which is basically this idea that reproduction is really important for a family of a wife and a husband, but also for, in many settings, a broader family group. And this is because children represent the continuation of a family lineage and allow then for the maintenance of a lot of traditions and wealth, and provide for parents perhaps in old age and a variety of other things, right? So especially I make the argument that a first child really solidifies a woman, a wife's place in her husband's family. In many cases, when a society is patrilineal, the wife marries into his family, the children become part of her husband's family line. And so she kind of has to earn her place in that family. And in many instances, that's through successfully having children. And so in this context, if you think about needing to have an alive child in order to solidify that place in your husband's family, the stakes are high. And often what I've seen in Tanzania, it's mothers-in-law who accompany women to give birth at facilities. They wait outside. In the case of Kigoma, where I was looking at this birth companion program, often the companions from home that people brought with them were their mothers-in-law. Sometimes their mothers, sometimes sisters-in-law, but very often mothers-in-law, because a lot of people would say the baby belongs to the mother-in-law. And so the mother-in-law is sort of there to make sure that her in-law is comporting herself well, is behaving, and is successfully giving birth. And some of this means listening to the instructions of the nurses, being compliant. Some of it is about not being embarrassing in that you don't make too much noise, or you don't cry, or other sort of displays of pain or emotion that are not considered socially ideal. And I tried to make the argument that this applies not just in biomedical facilities as well, but also is a value when in home birth settings, and midwives, traditional birth attendants or home midwives will also kind of police those boundaries by reprimanding people for making too much noise, or hitting them, or pinching them, or slapping them if they're not performing in a way that upholds these ideals of sort of womanly strength and good comportment in this important time of having a child. And I draw also on some of the literature from Erika Barton and her colleague in the article that's cited in the piece from 2010, where they're looking at similar issues in Cameroon and the importance of reproduction for solidifying family relations. And so in the context of that, then nurses are also often a product of the same cultural environment, right? So they understand a lot of these desires or the importance socially of these events. And so also kind of police these boundaries in ways that may be abusive as well. But the argument then is that they're caring not just for the woman or not just for the baby, but for the broader sort of social network and the kinship relations involved by ensuring that the family gets this child that they've been waiting for.
Great. Yes, that's very important insight. Dr. Okusanya, I don't know if you could comment on whether that would apply in the settings where you work as well.
Well, yes, it does apply to Nigerian setting. Typically, the average African community puts a lot of premium on childbirth. And Nigeria, in some parts of Nigeria, not just a child, but on a male child or a son. So it's incumbent on the woman soon after marriage to get pregnant. This is not an environment where people will say, oh, let me enjoy my marriage. I don't want to have a child or any children for the next 5 years. Most women will get pregnant within months of marriage and want to have a child within a year, if possible, within 2 years of their marriage. So it's actually seen as a social insurance, let me put it that way, within the community. Also, in some parts of Nigeria, women without children cannot be part of the community women's group. In some, still, if you have children but you don't have any male child, you are more like ostracized from the environment and from the community of women. So you can't go for meetings, or if you go for meetings, you're not allowed to talk or to make contributions at such meetings. So these are things that make women feel so committed to enduring whatever disrespectful or abusive behavior that they have while giving birth, just for them to be able to at least be able to speak and interact very well in the community. So there are things that actually occur in Nigeria and in different parts of Nigeria. There are also different contexts. Regarding painful expression of birth, not all communities also in Nigeria express pain. There are 3 major tribes in Nigeria: the Igbo, the Yoruba, and the Hausa or Fulani in particular. Generally, I know the Yorubas have a very low pain threshold, and they usually express pain a lot while in labor. While the Fulani, which are from the northern parts of Nigeria, have been trained never to express pain. And unfortunately for them, many of them have so much pain because of uterine hyperstimulation and go into uterine rupture without even expressing any form of pain until they go into shock and one realizes that they actually had uterine rupture. So there are different cultural aspects or cultural norms that actually either encourage or discourage women from expressing pain, even in Nigeria, as I want to believe it's applicable to different parts of the world, including sub-Saharan Africa.
That is really fascinating, isn't it? I think that's a whole other topic, the pain and expression of pain, but the cultural aspect of it is very, very important component. Did you want to add anything at this point?
Yeah, just another interesting aspect to pain culture is, like Babs had mentioned about the Fulani women, we actually have a lot of evidence to even show that even many of them prefer to give birth with no one present. So there are many articles that has been written from Nigeria where we have about 60% of Fulani women, because the cultural expectation is that they're not supposed to show pain, they should be able to have their babies by themselves. So they don't even ask for support during childbirth, not even just skilled support or skilled providers, but no support at all. So that's also another interesting dimension to to add to why, just to buttress the points around social risk, social expectations, social insurance, So there are many factors, complex factors that play around social expectations and the outcomes of birth or the performance of the behavior during childbirth. I'm also a Nigerian woman, so some of those things are kind of like home to me. Yeah, that expectation about having a child immediately. I remember when I first got married, my father-in-law was like, "Oh, yeah, we're expecting a boy, and it's going to be in 9 months." And I said, "No, it's not going to happen." So, yeah, so these are realities. These are, and it doesn't matter your education. I mean, I met my husband when I was already a physician. So I think my in-laws, I was already a physician, trained internationally in some ways. And yet, despite that, I couldn't really resist or fight those expectations. So yeah, just to buttress the points from Dr. Strong and Dr. Okusanya that there are realities of these women, and so we have to consider those when we're planning or doing anything to improve respectful maternity care.
So that obviously poses some additional challenges for global maternal health policy in the local settings. But Erika, I think you had a couple more questions.
Yeah, as a public health student, I'm very curious as to what interventions can, be effective at preventing this sort of behavior in either a hospital setting or a setting in Tanzania's hospitals. For anybody, that's an open question.
I think we've already touched on some, but feel free to reiterate some of the interventions. Yeah.
I mean, I can just say part of my study, of course, was around this birth companion program that was designed by some public health people in partnership with Columbia University and a local NGO in Tanzania. And it was not only about reducing disrespect and abuse, but they were hoping that that might be sort of a side outcome that would happen. They were hoping that by allowing women to have someone from home with them during the full duration of labor and delivery in the health facility, that person might act as an advocate for them and perhaps intervene if a nurse started slapping them or yelling at them or something like that. And that's not what I ended up witnessing. And I try to argue in the article that I hypothesize one of the reasons it didn't quite work that way is because older women from the community who were often these companions also were part of this same idea, the same environment of understanding that hitting is sometimes necessary. And so they would even sometimes advocate for hitting the person they had come with, which I found distressing sometimes. One time I remember very distinctly, the midwife was with the woman in labor in one of the delivery rooms, and her companion, who was supposed to be with her in the delivery room, was on the other side of the room, on the other side of the ward, and heard her relative, I can't remember if it was her daughter or daughter-in-law, and just yelled across the room to the nurse in front of everyone else, right? I mean, there were many other patients in the ward at that time and things like that. And just yelled across the room to the nurse to just hit her, just hit the patient. And I was like, wow, okay, so clearly this is not going to be the mechanism for reducing disrespect and abuse, because now you have just another person who might be advocating even for abuse of the patient. And certainly I think there were other people who would not agree with those behaviors, but are unfamiliar with the healthcare environment. They're in a position where they're just there as a guest and they don't really know what they are and aren't allowed to do very well, perhaps. And they certainly don't have the authority to push back against what the nurses are saying in this setting. And there was no sort of mechanism where they could go report to someone and know that that person or people would then come in and address the bad behaviors or anything like that. So they were really stuck in a position where they might be afraid if they talked back to the midwife might abandon the woman entirely and just go help someone else and leave her, because now the patient is being seen as difficult, but then also her relative is now seen as difficult as well. And so the midwife might just be like, I'm not even going to pay attention to you. If you don't want to listen to me, I have other people to deal with. or they might kick out the companion. And so there were a lot of ways in which I think there was potential. We have a lot of literature that shows that people tend to have better outcomes in a number of ways when they have a companion with them, particularly someone they've chosen and they trust. But in the settings that they were implementing this program initially, we were still missing some pieces to make this an effective intervention for reducing disrespect and abuse. And I think we can learn a lot of lessons from this and try to come up with a way that a similar program could work more effectively with that as one of its primary goals. And it certainly had benefits in other ways, but just not, I think, really in reducing disrespect and abuse, because it was lacking that mechanism for accountability, and there were still those power dynamics that I think made it difficult.
Yeah.
Mm. Probably not anticipated by the donors. But Dr. Okusanya, do you have any further ideas, or would you like to reiterate maybe a suggestion that you already touched on in terms of interventions to prevent this type of behavior during the second stage of labor?
Yeah, one thing that is key is that in many parts of sub-Saharan Africa, analgesia during childbirth is either not given or suboptimally given. So if there is good use of labor analgesia, more women will feel less pain, more women will cooperate with the caregiver, and there will most likely be less disrespectful and abusive behaviors. That is one. Secondly is the fact that one of the evidence of companionship in labor is that because the women themselves are with someone quite familiar with them, not the caregiver, they are with the sister, they are with the husband, they are with the mother-in-law, or even our own mother. This alone psychologically makes them feel less pain and also reduces the need for analgesia. Or if at all, if they will require analgesia, they get less dose with a wider frequency. So there are other advantages of companionship in labor beyond acting as a guard in quotes to abusive tendency of healthcare workers. The fact that the woman is there or the husband is there rubbing the woman's back tends to make them feel less pain and feel less need for analgesia. Then the last thing I would like to say is that healthcare workers need to be reinforced that there's actually no benefits in being disrespectful or providing abusive care for women. And that can be done at every opportunity, irrespective of the kind of training they are having, as long as it has to do with caring for women who are pregnant or in labor. There should be a component of that training that emphasizes respectful maternity service provision.
The idea of including husbands, I've always thought is really important. And in this program, the pilot program that I was observing, they had long conversations with the community members and with the healthcare workers, and ultimately decided that they were going to require the companions to only be women. And I felt like that was a lost opportunity, because I think there are a number of men who would have liked to be there with their wives. And also, I wonder if men being present actually might have decreased the incidence of disrespect as well, because they're seen to have more authority in a lot of ways in these settings. And so and also I think for men, it would be great to see the work that their wives are doing when they give birth, because a lot of them are unfamiliar and just want to have another baby. And they think it's as easy as that, right? So I think it's so important to kind of expand our minds about that. And even in Tanzania, to talk to people about the importance of having husbands or male partners involved, because I think that there's so much more we could accomplish with that as well.
Yeah, I quite agree with you. There is a lot to actually learn from it. I've seen a man experience his wife's birth, and after the experience, he said, "No, I will not go near this woman for the next 1 year. She has suffered a lot." But having said that, I think why many people are shying away initially from male companionship because of the nature of childbirth and the facility in which the childbirth is going on. For instance, if you have a very large hall with all women on each of the beds in a large hall, that's not an ideal place for men to be, because some of the women will be even not naked, they will not have clothing all over themselves. However, in a place where there are individual bathing rooms with doors, the woman can stay there with her husband throughout, and then for such an instance, the man will also like that kind of environment. Also, many men won't like to be in a place where they're just seeing different kind of women and they are seeing them laboring. It's the men can also have post-traumatic stress disorder from experiencing the experience. So I think we also need to protect men to some extent.
Yeah, the infrastructure is such a huge contributor to why in this program they decided they wouldn't be able to do that. And it's a shame because I think we're missing out on some opportunities. But I think that's also when we move forward and public health people are making recommendations, or government policymakers are approving plans for new hospitals and things like that, we need to think in a different way so that we can design from the beginning infrastructure that will then support some of these other opportunities for the way that might improve care for everybody.
Right.
Yeah, interestingly, I see this as long-term and short-term, plans. My work in public health has really been to improve, maternity, experience. And something I've realized is to change behavior takes a long time because these behaviors are really entrenched, they are cultural, and the determinants are very complex. And so if we focus on sort of like the provider's behavior, at that point, I think we need to think along the continuum. There are immediate behaviors that things like putting out, I've had a hospital system put out a strong worded letter to their midwives. This is what we will tolerate, this is what we won't tolerate. And I think having legislation with some of those things, it doesn't mean that if the legislation is there, people are going to change, no. But it helps, it's a step in transformative change. That's one. Secondly, just employing some of the tactics in behavioral economics, creating some small tweaks within the health system or within the hospital or facility can help improve or change behavior of providers. I wouldn't want us to put this burden on women. I have 3 kids. If you've never been in labor, you have no idea. You have no idea. But when you've been through it, and I'm sure some of us in the room, you know that you can't really control your behavior. Whatever comes out of it is what comes out of it, is how you feel. So I wouldn't want to put the burden on the women, but rather the burden should be on the health provider. How can we provide better supportive care? And how can we empower the provider also to be able to provide that care or make that change in behavior? So putting things in place like providing the right structure, like we've talked about in terms of functionality, giving them simple tools that will work, particularly in areas where there's limited resources. What kind of tools can we put in the hospital to improve, to help everyone from being stressed? So a simple example is a pathograph. It's such a simple tool, which is the pathograph is, it helps clinicians or midwives to monitor the progress of childbirth, to know which one will become an emergency as at the time you're there, or which one do you need to refer, or, all those things. Now, the pathograph, what we found out is that a lot of providers do not use this pathograph. It's a simple tool. It's not the end, to the means. It's not the all in all, but it can really help a provider to make some quick decisions and be more confident in the kind of care they provide and say, based on this. And it's also protective in terms of if there's litigation, if you show how you've used your pathograph. And this can be used anywhere, whether in a rural hospital, where you don't have the monitors. So those kinds of tools, I think we need to really get the systems, provide the curriculum to teach adequately, help providers to use these simple tools to improve their confidence and also to gradually tweak and change their behaviors. For example, even on the pathograph, if you put a reminder on your pathograph that you do not have to hit the woman to get her to do this. Those simple communication tools, I feel they can really help move, change individual behaviors. At the transformative level, definitely there should be legislation because it's entrenched. So legislation, support, providing functional structures to help providers give better care. I think that would be a step in the right direction. And also part of what I talked about performance-based financing. So if these providers, if they get incentives for good feedback, for example, if you do a survey and women said, oh, we had good respectful maternity care, during labor, the labor and delivery went fine, they did what they were supposed to do, or these were the issues, I think we can better help the providers to change their behaviors, to say this is how better you can do it, and they can get incentives. So incentives not in terms of money, but incentives in terms of recognition, incentives in terms of awards. These are the kinds of things. And even just taking the providers through training, you bring in a specialist who is embedded for maybe 2 weeks and goes through the birth and helps them with the techniques. I feel like those kinds of things can really just help move things around. But in summary, it's a complex thing. It's complicated, it's complex, and it's nuanced within the culture and the locality. So sometimes we need to dig deeper, understand what the issue is with that facility, and now make those changes to change behaviors and also improve experiences.
Great. So it's clear that we need interventions at many different levels to address these issues. And I like the idea of the behavioral economics, using environmental nudges to encourage these behaviors. So is there anything else that Dr. Strong or Dr. Okusanya that you would like to add?
Just going along with the same idea of sort of positive motivation and recognition for people, the nurses that I worked with for the longest amount of time in Tanzania, they were on this very busy maternity ward and often felt that their superiors, the administrators or the other nursing supervisors and people like that, they were out of touch with the difficult environment that they were working in. And then also, they felt like they never received any recognition when they really went above and beyond and were working really hard to save a baby or save a woman or treat patients well or whatever. And they constantly were receiving criticism that was delivered in an anonymous sort of way, like, we have heard that there's bad language on the maternity ward, and there are no really actionable specifics. And it really brought down the morale on the ward for all of the midwives working. And one of the things I proposed that would be small and basically free was just for them among themselves, and I know they do this in other facilities, but among themselves, just to elect a midwife of the month. And then that person could maybe have a certificate or have their picture posted on the notice board at the doors of the ward so that everybody could see that this person was recognized by their peers and colleagues as providing really good service in the last month or something like that. And then someone feels like, okay, at least even if I'm not getting extra pay, which would be lovely, at least people see that I'm good at my job and I'm working hard for something, right? And I'm getting some recognition. And I think it's small things like that that can also change just the way people feel about their work, and also on those really difficult days can help them stick with what they know is the right thing, which is not hitting the patients. And it maybe gives them a little bit more patience to wait with that woman or to try other techniques or put up with the bad technology that they have to work with or whatever it is. But if we can't support healthcare workers in these environments in ways that make them feel seen and valued, then I think we're also missing part of the equation. As Abby said, it's very complicated, and we have to really look at this holistically to improve working environments, and then interactions, and then outcomes, and better experiences for everyone.
Mm. So yeah, that's very interesting, because we're kind of ending up where we started out, which is motivation, and it's all down, what motivates the nurses to practice these behaviors, and how can we maybe shift the motivation. I know I worked in Indonesia with midwives and people within the health system, and they very responsive to those kind of reputational motivations, certificates and so on and so forth. I don't know if it's similar in Nigeria, but Dr. Okusanya, can you comment on that at all? What are the sort of motivations in terms of nurse midwives' career motivations? Is anything being done to improve that?
Well, generally, every health facility will have to develop a motivational structure for its own staff. And one thing that I know will cut across virtually all facilities will be the scheduling of duty, which is a reflection of the number of staffing. For instance, while I was doing my PhD fieldwork, I realized that in some places, some nurses worked 12-hour shifts because they had low manpower, and that's the only way they can cover the facility. And this was a 24-hour primary healthcare center. While in some other places, they do 8 hours because they have more manpower. So if the manpower strength is good enough for them to do 8 hours, of course, each time you go off duty and you come back, you are refreshed, the chances that you'll be irritable or irritated will be less, and the chances that you perpetuate disrespectful or abusive healthcare will also be minimal. But you can imagine if someone had been on duty for 12 hours, it's at the 11th hour, a woman comes in labor, when she already opened that, oh, thank God, my shift is almost coming to an end. At that point, of course, she'll be very unaccommodative, and it could actually be a problem. So I want to believe that appropriate staffing based on the of that facility will make one of the ways to motivate the staff. That is one. Two is that occasionally staff are also denied their privilege of going on annual leave or taking some time off to attend to personal issues. For instance, I know of places where they will say, oh, if you have not gone on annual leave, then if you need 1 day off, that 1 day must be from your annual leave. When the government policy also says that if you need just 1 day off, you can take that 1 day off, irrespective of whether you have gone on annual leave or not. These are small motivations that staff could have that will make them have a very receptive to patient care and make them less liable to providing abusive and disrespectful care for women who are giving birth. Unfortunately, most of these things are actually at the small micro level, at the facility level, where the head of the facility can actually do, but they tend to be very, very strict and want to always adhere to the rules without knowing that they have to have some form of human relations, even while trying to implement the rules.
Maybe just also to add is something we've seen work is positive deviance. So part of my work in Nigeria, we would go to this tiny villages, and you sort of go to a very small facility in the middle of nowhere, and you see the staff really performing so well, recording, doing all those things. And sometimes I would ask the staff, so what made you do this? Oh yeah, I learned this and I feel like this is what I can pay back to my community, and I do it so well. And you see the staff really happy doing the good work. So something that has really worked is using that staff as a positive deviant and using that staff to influence surrounding facilities, or sort of like associate facilities. That also helps because just to bear in mind, health workers, they see their patients, they want to do the best for their patients, but they also want to know that what they're doing really matters on a big scale. So when you provide that opportunity for them that, the little work that you're doing so well in this facility, you can actually be a trainee, you can be a change maker across multiple facilities. This would help you also improve your CV, so everyone is aspirational. And so we should never forget that at any level of health worker, where you find a health worker, everybody wants to make sure they're not just spinning the wheels, they're doing the work that makes a difference. And so once we bring that up, we're going to see it's like little candles that light up the whole area. So if you let health workers know that, or provide the opportunities to, or demonstrate that what you do here goes a long way. It matters, it influences other facilities, it goes across the state. I think I've seen it work. It makes a big difference. So a health worker who is just in a small facility gets called up by the Minister for Health of the state and says, oh, wow, your name came up because we've seen what you do. Then all the other staff, you see the competition, like, oh yeah, I didn't know we get recognized by doing this. I think those are just like simple, but we need all those multiple kinds of interventions that can really motivate the staff. And, beyond pay, because sometimes pay is not the motivation actually for staff. Sometimes they're not interested in, everyone wants a salary increase or a pay rise, but not all the time. You can get people to bend over backwards, even by just simple recognition.
Great. Well, I think that's a nice positive note. I think that's been a very rich discussion. We'd love to continue all day, but I think we all have, I think we've really addressed the main questions. So I'd just like to extend my thanks again to Dr. Strong and Dr. Okusanya and Dr. Okechukwu and Erika. And thank you very much, everybody.